Hi, thanks for joining everyone. Um, Guys, you can hear me okay online, just checking again. Sorry, you did say yes before, I think.
Yep.
Fantastic, thanks guys. Okay, we're going to use Bob to try and show how to do a full TOE, a full study. I'll probably take about half an hour doing that, if that's okay. And please interrupt me at any stage if you want. We've got a couple of people online and a couple of people in the room, so if anyone talks and they can't hear the other person, let me know. Okay, guys, transesophageal echo. You're going to have your handle, and on your handle, you're going to have some buttons and two wheels. All right. So first of all, which does what? So let's start with the smaller wheel on the outside. I'm just going to show it online first, and I'll show it elsewhere. So if you go to the you got the wheel on the outside does the side to side. Okay, so you can sort of see it moving one side to the other. And then if I rotate that probe and do the big one at the front, you can see it moves up and down. Okay, I'll try and show that now in maybe front on might be a little bit easier to the probe. So if I'm moving the big wheel at the back, you can see that moves. That's what's known as retroflexion, and that's known as anti-flexion. So just to the guys here, trying to keep an idea of where the plane of the moving image is. So that's retroflexion, and that's anti-flexion. Okay, that's smaller wheel on the back, that goes from side to side. First movements, all right? The next movement on here is those little buttons that we've got on the handle, as I'm sure you've all seen. If you can see the omniplane up at the top there. That's going to move one way, and it's going to move the other way, and you can sort of see how that moves on Bob on the left. That will all become a bit clearer as we sort of continue. So when you're sticking the probe down, I classically do this just so I don't know if you can see online, but I classically do it so I'm standing on the patient's left. So I got Bob sort of standing down there like that. So I stand on the patient's left, and then I sort of holding the probe in my right hand, holding the handle in my right hand to move the wheels with my fingers and move the buttons with my index and middle finger. And then I'm putting it in that way. Okay, so first thing as I'm putting it in, it's easy to get lost. So I figure out with the big button on the outside, which way is up and down. And you can see that's a plane of movement, right? So that's a retroflexion and anti-flexion. And I'll put my finger in line with that, a thumb. Because then when I put it in, I don't get lost. And you can see as I put it in, you have a look how Bob is then being dissected. He's being dissected across that way. All right. So if you're having difficulty trying to imagine how this is all working, I imagine that this is again, I'll see if this works online, see if you can understand me. If you can imagine that the big, long, wiggly bit of your toe probe is your arm, your right arm, okay? So your right hand is the toe probe, your wrist is the ultrasound bit, and then your hand, and it's got to be your right hand, is the image that's coming out from the ultrasound probe, okay? And your right hand, I don't know if this is going to work online, but your right hand is that picture, okay? So your thumb is the little nubbin up at the right, this little nubbin up here, okay? Yeah, so your right hand is the toe probe, and then your right hand is the echo image. So your thumb is on the right side of the screen. Cool? Yep. And that's why it's going to be important for this next bit. And then again, trying to imagine where the echo image is, so the probe is, imagine you're standing at the top of the patient's head, putting your hand down into the patient's hand. Okay, and that's the equivalent of doing this. Right way around. Okay. So as you put your hand down into the patient, it's like doing that. I might just change some of the settings on Bob just to give us an idea of what we're looking at. Beautiful. Okay. So I can't do two things at once. It's a bit hard. Okay. So as I put the toe probe in and I sort of lower my hand down through it, just dissects him like you're doing axial planes, right? That's really important because then if we're talking about this omniplane, as I increase up the value, you can see which way it turns. And this is why you have to use your right hand when you're imagining this, because your hand turns like that inside the patient. So I'm going to ask you a question now, Desh. Always start with the echo, I do apologize. So if I've put my hand in, like, let's find the heart. That's pretty good place to start. I'm going to keep it quite the. Okay, so as I put the probe in and I start going down through the heart, I'll get myself a 4-chamber. Because the omniplane, so I'm going to try and. Okay, so if I'm looking at a short axis like this, okay, so I'm cutting that heart across it. As I move the omniplane up to 90 degrees, look what happens to that image on the left about how it moves. Okay, so if I move it to 90 degrees, that means I've gone from short axis, cutting it through, and I've moved it around to long axis. Yeah, nice. Yeah, maybe I'll try it with the apical one. It's just Bob was giving me some trouble. Right, there's a 4-chamber, right? So there's a 4-chamber. If I now move the omniplane up to 90 degrees, I'll get a 2-chamber, okay? Because I've cut across that heart, then I've moved at 90 degrees in like a biplane view. So my question to you, Desh, is which wall is which? Because if we go from an apical 4-chamber, where we've got our infraseptal and anterolateral walls, my apical 4-chamber, and I've now moved up, you can call it 60 or 90, we can argue about that later. Which wall is anterior and which wall is inferior? The one to your left is, hang on, so remember, as you go around like that, this is why it's important to have your thumb as being the little marker on the left side of the screen. So if your marker goes around like that, that means that's anterior. Your omniplane is always going, so you've got to use your right hand because you can't turn another way. So your right hand is always going like that. Just supinating and antenating your. Very nice. And I'm sorry, I hope I'm not confusing everyone online. It's just. Absolutely, it's just, I think they're beautiful. I think whatever if it works, it works. I've got to be honest, I've been trying this for about 10 years trying to teach people like this, and I get the same looks whenever I do. Some people get it, like 10%. Yeah, it's just an idea. If you're, I'm quite a pictorial learner, and I guess this is what helped me. Okay, so let's move on because that confused people a bit. Just in the meaning of time, I'll keep moving. Okay, watch as we push this probe down through the heart. You've obviously got the esophagus sits behind the heart. Sorry, Bob is not playing at the moment. There should be a. But you can sort of get the idea. Yeah, absolutely. So the red bit is your thumb, which is that marker there. So this is me looking down on the heart from the top. Okay, so obviously we've got the esophagus behind the heart. So everything that you're looking at that's closest to your probe is going to be posterior. Okay. One of the things I want that took me forgive me if I sound stupid, but when I first started, I didn't realize the 3D orientation of the esophagus. Because just watch how this plane changes from dissecting that heart sort of an axial plane. As I start to get to that point there and I start to push it around, can you see how that plane now changes? The esophagus comes behind the heart and then curves anteriorly. So you have two different kinds of planes, depending whether you're in the mid-esophageal view, which is what we call this, where the four-chamber is, to where we get to sort of like the upper gastric view, which is there, which is where you get the short axis. Okay? The first thing to notice, you're dealing with three-dimensional structures, obviously. And I didn't do anything. All I did, you can see, is I just pulled in and I pulled out. Yeah? And that's me just pushing in. Okay? Yeah, nice. Okay? So, okay, so we've gone through sort of some of those motions. Okay, one of the last thing I'm going to start talking about is maybe the movements that then we're doing with this side of my hand. So I can obviously push this probe in and out, as I just showed you. I can also then with my hand look from one side to the other. All right, you see what I'm doing? Just like with a bronch though, if I hold my hands, I'll try and say something. If I have my hands sort of close together like this, and I rotate, you can see it doesn't really move around much on the screen. You've got to have your hands, just like a bronch, they teach us to have your hands quite far apart. Same thing with this, because then if I do little movements, you can see it, the movement of the image is quite extensive. I guess rotation. All right. Nice. And I always talk about rotating it versus the patient. So I talk about rotating to the patient's left and rotating to the patient's right. All right. And the way I try and again, oh, actually, I'll stop with my right hand. The right hand helps. Just trust me. Just go with it. It'll click one time, and we won't be together. But I want you to tell me when it's clicked, and just let me know that I'm not talking utter bollocks the whole time. All right. Anyway. Don't even give me an interpretive dance for the ventricle. That's the next thing we'll get into. Anyway. Nice. Right. Okay, so let's talk about how to do a full study. And the philosophy I've got with transesophageal echo, and it's the same with transthoracic, right, is that you've got, and it's the same with clinical exam, is that we've got a pattern that we do our clinical exam in, but you've got to be opportunistic with if it's important, such as, I don't know, if you suddenly find crackles in the lung, I'm going to start having a look at feeling things like heartbeats. I'm going to have a better listen. I've always the heartbeat. Have a better listen to the heart. Probably think about echo. I'll look at the legs. Thinking about whether you've got LV dysfunction causing crackles, right? Causing creps in the base. Same thing with a transthoracic echo. If you come across TR, we're going to go and interrogate that pulmonary hemodynamics in a bit more detail. Same thing with toe. Except the difference with this one is that the more movements that you do in the esophagus, the more chance you've got of causing damage. So we are trying to minimize movement within the esophagus. And that means that if you see something, grab it and go and interrogate it. So just try and be opportunistic, I call it, but don't forget that we're trying to minimize damage. What I'm going to show now is just this whole pattern of how I do the full study, because the movements that I'm trying to do to minimize the movements is I'm going to start down what's known as the deep gastric view. I'm then going to go to the upper gastric view. I'm going to go to the mid-esophageal view. I'm going to go to the upper esophageal view. I'm going to look to the patient's sort of right side and left side as I do each one of those movements. And then the final thing I do is I go and find the aorta. I follow it all the way down until I lose it, and then I come back out, okay? So I do two movements. I basically insert the probe as far as I need to go. I'll come up to the top of the heart, look at the aorta, again as far as I need to go, and then come back out. That is not how everyone does it. I'll understand probably cardiac anaesthetist will have a slightly different way of doing it. Cardiologist different again, but that's the way I do it. And it's all about minimizing movement within the esophagus. So I'll show you a way of doing it. I don't care which way you do it, as long as it's systematic, you don't miss things, because we're never doing a focused toe, in my opinion. If you're going to go to the trouble of getting a probe in, you've got to do a full study, right? Okay. So the sequence is deep gastric view. This is the one, if you've got an awake patient, is the most uncomfortable. This is also the one which is the most likely to cause damage because we're going to be doing the most aggressive move. Bob can't show you this very well, but I'm going to show you the principle. Okay, so I'm starting as low as I need to go. And the deep gastric view is one where we look back up at the heart. So I go until I can see, I can't see any sign of the heart any further. I keep pushing, I keep pushing, I keep pushing, and then I start doing until I can't see anything at all. Okay, and then I do anti-flexion, and I can then look back up at the heart, trying to see this kind of view. That's not bad, actually. It's pretty good. So this is what's known as a deep gastric view. And you can see here, one of the problems that we got with toe is that the angles for Doppler are often a bit rubbish. And that's great because you can do off-axis imaging with transthoracic imaging, but you can't obviously do that very well with toe. So there are only sort of maybe 2 great angles that we've got for looking at the aortic valve, and this is the first one. All right. So that means that, again, if we're going to use the hand analogy, I've gone all the way back, and then I'm looking back up at the heart like that. Very nice. Okay, but it's full anti-flexion. And if you could see sort of the probe, you know, the probe is bent right the way around, and that's why I don't want to keep my hand in too long because I don't want to break Bob. But you can imagine that's quite uncomfortable because you're pressing up against the stomach lining, and hence it can be quite uncomfortable. All right. All right, after that, you notice I'm still keeping it 0. I can then come and have a look at the apex of the heart, the mid-papillary levels, and the mitral valve level, or the base of the heart. Yeah? So my question now to Adam. Adam, we have 2 kinds of papillary muscle. You've got the anterolateral and the posteromedial. Which is the one that we're seeing up there? So you've got anterolateral and posteromedial. Still at 0 degrees, yeah. Excellent. Fantastic. So Desh, we've got 6 segments to the heart when we look in the short axis. Anterior, inferior, anterolateral, anteroseptal, infralateral, infraseptal. Which segment is my cursor on? Excellent. Cool. Nice. So that's at 0 degrees. So I'm now in that upper esophageal level or lower esophageal level, whatever you want to call it, upper gastric, lower esophageal. I'm now going to start moving around, and I move from 0 and I move up to 90. Okay, and I try and get a 2-chamber view. And here I'm going to have the one closest to the probe is going to be your inferior, and the one furthest away is going to be anterior. Yeah. And I can look on my left side of the heart. And now what looks in the move? So I moved from, again, see how the scroll moves. I've moved from 0 up to 90. And now I'm going to look at the right side of the heart. So if I'm looking at the left side there, if I start rotating my hand, you can see I now start fanning through the heart almost. When it was like, when I was in 0 degrees, it looks from one side to the other. That's sort of out of, that sort of in-plane movement. Now I'm out of plane movement, where I can look from the left side of the heart there over to the right side of the heart there. And you can start to see the tricuspid valve at the top of the screen there. And just at the bottom, just coming into the screen there, is the pulmonary valve at the bottom. And that's where we can start doing some Doppler analysis. It's often off axis a bit for pulmonary hemodynamics. All right. The next one is I come up to 120 and I look to that patient to try and find the aortic valve. And you can just see it sneaking in there, right? And this is the other angle at 120 degrees that we can sort of start to get an idea of what aortic flows might be. If, for example, we've got infective endocarditis, have we got increased flows? If you've got a prosthetic valve, have we got abnormal flows? But what you'll notice is if I start sticking say a continuous wave Doppler profile on it, I'm way out of axis to actually where the actual flow is. And remember that the machine thinks you're perfectly in line with the movement of the blood. So you're vastly underestimating what the flows are, but it's the best that we got with tone. So you just got to grab what you can. So I find it hard to make accurate estimates of what like a valve area might be. But if you get significant stenosis, you can normally pick up something. Yeah. Right. So that's everything at that lower level. No, I don't know. I'll get rid of that. Cool. Okay, back to 0. Then I'm going to come up to my esophageal, mid-esophageal level. Okay, and as I come up to my mid-esophageal level, again, you'll see the angle change. You see that angle change there from being in a sort of gastric level to the mid-esophageal level. And we start looking down at the heart. But you'll notice that I'm cutting that heart sort of off axis. You see the heart looks like a circle. It looks like a soccer ball. And we want it looking like a rugby ball. And so my question, again, let's start with Adam. So my question to you is, you see that plane is not, I want it down the sort of long axis of the heart. What movement does? So what I'm going to do now is with my thumb, I push the wheel sort of away from me, if you like, and that's retroflexion. And that means that I start looking down at that heart a bit more. All right, try and get it. Yeah. And you can see if I antiflex, I kind of lose, it looks like a circle, and as I retroflex, it gets longer and longer and longer. One of the things that Bob's not great at showing us is, but one of the things I look for is remember that the base of the heart moves towards the apex is fixed. So I try, if I think I'm off axis, you'll see that apex of the heart moving like that, right? That would be an indication for me that it's off axis. When you're actually on that full long axis of the plane, you don't see that apex of the heart move. Bob's always moves, but that's yeah, he's not perfect. He's pretty close. I'm now going to stick color Doppler on each of the valves, tricuspid and the mitral in turn. I'm going to look at the function of the LV. I might try and put some color at the apex to make sure there's no blood clots if you've got apical akinesis. I'll move to have a good look at the right ventricle. We don't have any really good way of assessing the right ventricle objectively with toes, so it's a lot of it's subjective analysis. So just looking at that RV free wall in particular and how that lateral annulus moves. And it's just kind of a bit of guesswork and a bit of experience. After that, I move back to the LV. Okay, so from that's sort of the perfect sort of 4-chamber view. I'm then going to move, just rotate it around a little bit more so that the LV axis is then in the middle of the screen. Very nice. So I'm going to try, let me see if I can. So if I imagine a line down the middle of my probe like that, I have my, so that's my 4-chamber view that I had before. I'll then tilt my probe slightly round so that then the LV axis is down the center of my image. Because then when I start rotating the omniplane, what's in the middle of my image on one plane will stay in the image on the second plane. So if I now come up to, say, 60 degrees, I've now got, so I'm trying to do 2 things at once. Pretty hard to be honest. Let me show that again from that angle. Okay, so I'm looking down at the heart. I'm going to move over so the LV axis is in the middle there. And you'll see how that omniplane then moves around from 60, that's the 2-chamber, anterior on the right, inferior on the left, round to 120, where I start to get my 3-chamber view. And that's like your apical 3-chamber view. Yeah? And so it's just like transthoracic 4-chamber, rotate round, 2-chamber, rotate round, 3-chamber. That's why you need your right. As I look in each one of those views, I'll zoom in on the valve, I'll put color Doppler on the valve, we'll maybe talk about the mitral valve leaflet scallops a bit later. I think that's, let's just get a head around what we're looking at first of all. And if I get lost, I always just come back to what I know. And what I know is my apical what I know is my mid-esophageal 4-chamber. So come back down to 0, find your 4-chamber, a little bit of retroflexion, and away you go. One other little tip and trick I've got is that before I do my retroflexion, I sometimes just pull the probe just out until I start to see that aortic valve come in. You see that aortic valve starting to come in? Then I retroflex. So that can be another sort of like pivot point for me, just to try and get me. As I'm pulling back, just as I'm trying to find my mid-esophageal 4-chamber view. As I pull back, I just start to see a little smidge of the aortic valve coming in, and that tells me that I'm, up in that mid-esophageal region. Then I do the retroflexion, and that normally gives me a pretty good view. So you're looking at that LV then at 0, 60, the conjural view, 90 degrees, and 120. And that assesses that mitral valve in all its areas. But remember, this is a 3-dimensional structure. You've got a 2-dimensional imaging tool. So even as you're rotating through, to make sure you don't miss small stuff like small infective endocarditis or something, just keep an eye on things as you're moving, and not just doing it at 0, just doing it at 90. You're trying to assess it in multiple areas. Okay. As I'm doing this, I'm going to check out a couple of other things as well as the LV and the mitral valve and the aortic valve. I'm going to look at 110 degrees. I try and find this little nubbin in there. What is that? So Louise, I know you've done lots of toe, but left atrial appendage, beautiful. Just above this, we've got they call it the Q-tip or the Coumadin ridge, or Marshall's ridge. It's not the ridge of Morgani that I have been calling it for. I think I called it the ridge of Morgani for a decade, until someone who actually knew about anatomy told me that that's actually the ridge in the anus. Is the ridge of Morgani. So maybe you don't trust me on my anatomy. I know how to do toe. My anatomy is a bit rubbish. So it's not the ridge of Morgani. It's Marshall's ridge, the Q-tip, or the Coumadin ridge. Above it, in there, you have to always do a little bit of rotation one way or the other. In there, you will find often the left upper pulmonary vein. Very nice. You can just see me dissecting it into it there. But you've got to do little bits of sort of rotation around to find it. I guess another tip and trick is, just like with transthoracic echo, where little movements can make a big difference, particularly when you're looking for things like the left atrial appendage and the pulmonary veins. Just do little clicks of the button to move, angles, little bits of rotation. You don't want to do big motions. You don't, just do it slowly in little clicks. That was all of that was the mid-esophageal. Yeah, so maybe I'll show it one more time again. So as I pull back, so I'll go down from so if I go, gastric view or upper gastric view, I keep on pulling it up, I'll start to see the aortic valve come in. I'm going to do retroflexion. So I'll pull up until I see the aortic valve. Excuse me. Come on, Prof. So yeah, as you're just pulling back until I just see that aortic valve starting to come in, I'm then going to retroflex. That's my 4-chamber. I look left, I look right, I bring the left into the view, I'll zoom in on that mitral valve, etc. Once that's in the middle of my thing, I can go up to 60 for my commissural view, go up to 90 for what they call a 2-chamber view, come up to 120 for my 3-chamber view. I'll come back to 110 to look over to that patient's left. Look at the way I move my screen now. I look over to the patient's. If I stay at 120-ish, there's the aortic valve. But if I look to the patient's left, in comes the left atrial appendage. And then I'll go and try and find, by either going up or down, I'll try and find that left upper pulmonary vein if they're in sinus rhythm. We'll maybe talk about the left atrial appendage when we're talking about strokes and things. So I think it's really important to review it in 2 views possible, because you can go through the anatomy again. It's quite a large structure and you can miss things. All right. Yeah, the anatomy. Yeah, exactly. I'll have to use a heart dissection model to try and show you that, in case I get the words wrong. Cool. So that was the mid-esophageal level. Next, you go down to 30 degrees or so. And then we're going to look at the short axis of the heart. So as we pull back up from the mid-esophageal view, we'll start to get short axis. Bob's actually more like 60, so it can be anywhere between 30 to 60. I normally start at 30, but Bob's more like, yeah, maybe 50. And here you'll start to see the short axis of the aortic valve. All right. He's a little tricky, he's a little bit. Okay, so what are the cusps? Dr. Gahadi, let me see if I can get you. Okay, so you got 3 cusps in there. Okay, so what's my yeah, cursor on there? Non-coronary. It's non-coronary, it's next to the inter-aortic septum, inter-atrial septum. So that here you've got the left atrium, there's the interatrial septum, there's the right atrium, tricuspid valve, and RV sort of wrapping around. So there's there. So which is which? So where's the right coronary? Oh, where's the right coronary cusp? Yeah, nice. Beautiful. So I'll start with that left coronary cusp is the one next door to the interatrial septum. Cool. Excuse me. This is the trouble with me trying to multitask. Sorry, I am trying. So yeah, the non-coronary cusp is next door to the interatrial septum. The right coronary cusp is next door to the right ventricle. That means there's only one left, which is always the left coronary cusp. So it's sort of, and the other way around, if you're doing transthoracic echo, obviously you're imaging from the anterior, which means it also the other way around. Coronary artery, yeah, just there. Yeah, and if we look, yeah, there you go. How about that? That's pretty good, isn't it? I could show you the right coronary and the left coronary cusp. Yeah, nice. I'll have a look at the aortic valve, both whatever angle I found that's sort of the aortic valve in cross section. I then got 90 degrees, so here I'm at 36. I'll go there for up to about 126 or so, and I should see the aortic valve in longitudinal section again. All right. Now I'm looking from the back of the heart now. Sorry if you can't see it. Whoa, because I'm looking at the back of the heart there, and you can see I'm looking at the aortic valve in the middle of the ultrasound image. If I look to the patient's left, and look what I'm doing with my hand, if I rotate my patient to the patient's left, I see that left atrial appendage. If I rotate to the right, back from there, there's the aortic valve that comes in. As I then go to the patient's right, I start to see the right atrium coming in, all right? Which is this guy in here, okay? And if I come down, it's meant to be about 110. And Bob's not great at this view, I'll be honest, but he's normally more like 90. This is what's known as the bicabal view. And what I'm trying to see here is I've got the IVC, the right atrium, and the SVC. So Desh, which is which? Because you can, excuse me, it's a bit hard to do it. So you can see it, whoa. Okay, so there's the right atrium, that purple bit. There's the IVC coming in here, and there's the SVC at the top. So if I'm holding like this, this is the right atrium there. Which is which? Which is that one? Very nice. That means this is the SVC. Again, next door to the red line, next door to that little marker. And in here, this is where we can start to make assessments. In real people, you often see the left atrium above it and the intraatrial septum, so we can do some bubble studies and look for patent foramen ovales and stuff. But Bob, I guess he's not perfect, he's pretty good. We can also start dropping M modes down through the SVC and start to look for collapsibility. If we are doing that, I tend to prefer to do it at 0 degrees and just pull up a little bit. And I do it from there. So here we can see there's the aorta, and right next door to it is the SVC. Okay. Absolutely. So I've just pulled it up a little bit into the upper esophageal. Thank you. So we're sitting here, I mean, in a real person, in Bob here, I'm at 35. I normally think it's a bit less than that. It's normally about 25, I think, 25 to 30. Okay, so let's, yes, SVC is here. Yeah. Yeah. So this is the aortic valve, right? So what's this? I'm going to move it up and down a bit. What is that? This at the front. So there's the aortic valve, you can see, because it's next door to the left ventricle. Yeah, you see that left ventricle on the bottom right? There's the aortic valve. I'm pulling back, I'm pulling back, I'm pulling back. What is it? Yeah, but pulmonary valve. The reason why I'm trying to show this to you is, imagine you've got infective endocarditis and you've got an abscess that we look for. There is a reason why you need to look for it, and that's because, much like the pancreas is, the surgeon would say the pancreas is where the soul of the heart, the soul of the body resides, because it's surrounded by everything else. The aortic valve is where the heart of the heart lies. You know, if you get a buggered aortic valve, it is right in the center of everything. You know, you're right there next door to the mitral valve, your SVC, you know, your right atrium, your pulmonary valve, you know, it's right at the center of that heart, surrounded by everything else. So having abscesses or infections in there is a big deal. But as I pull back, that turns into the main pulmonary artery, with the right and the left pulmonary arteries coming off it, okay, at 0 degrees. And again, which is which? So what's the one on the, what's that one there? Very nice, it's left, right? Because remember your hands, I'm at 0 degrees, I'm like that. So that means on your left, it's your thumb is pointing to your left, that's where the right side of the screen is. I'll turn it around so it's front on. Yeah, so it's the red to the left side of the patient. Yeah, very nice, cool. So you got your left and your right main pulmonary arteries. Once I finish that, I can rotate over to the right, and I'm rotating to the patient's left till I find the aorta. I follow that all the way down until and you see I have to rotate a little bit as I go down, just keeping it in the middle of my screen until you sort of lose it somewhere around about the stomach level. Try and find it back in. I'll reduce my depth. And then I look at it as I come up, and I'm looking for atherosclerosis. I'm looking for, you know, dissection flaps, looking for whatever. If I see anything, I'll rotate around 90 degrees and try and look left and right and all that stuff. And otherwise, just keep pulling up and optimizing your image as you go until you come out. Look at the arch. So here I'm sitting at the arch level. So I'll look to the patient's right as I come up, so rotating around, look at the arch. Yeah. Nice, inspect for blood. Trying it's, you know, we didn't really talk about contraindications. You know, blood is obviously not great. Looking for the contraindications would be someone who's got any kind of esophageal neoplasia. I think if you've got esophageal varices, that's a relative contraindication, but if they're actively bleeding, obviously don't stick it in there. Anyone who has difficulty swallowing, any kind of strictures, obstruction there, I guess, you know, neck abnormalities, things like that, just got to be careful. Big things I ask about if people are from bisphosphonates or steroids long term, that can be, and if you're over the age of 75, those are all increased risk. But pretty rare to cause problems. They talk about 1 in 5,000, 1 in 10,000 having some major esophageal damage. If it does happen, it is a major deal. And that's about it. I sort of went over a little bit there, but are there any questions? That's how you do a full study. Happy? Any questions online? Sorry, I know some of you do a lot of transesophageal echo, so forgive me if I'm teaching you to suck eggs, but we're just sort of starting the year off.
No, that sounds good. I feel like I cheat a lot and just use all of explain and 3D and color and stuff to try and make things easier and change all the angles. Use the expensive probe rather than my brain.
Yeah, very nice. I mean, I agree that the explain and the 3D are wonderful, but I do think it's important to be able to know with the 2D. It's like, you know, learning the fundamentals first, because then it's sort of, you get the added benefit with the 3D and the 2D, and we'll maybe go through that another time. Thank you. Well, thanks, guys. I think that's it for the session then, and maybe I'll see you guys next week. Thanks for joining.
If you learned something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.